Hi, my name is Ann Duplantis, and I'm a registered nurse at a long-term care skilled rehabilitation facility in Lawrenceburg, Tennessee. As a backup wound nurse, pressure ulcers are of great importance to me, and that's what I want to talk about today. Pressure ulcerization in a healthcare setting. Pressure ulcers are commonly called bed sores, pressure sores. Sometimes they're referred to as pressure ischemia or pressure necrosis. A pressure ulcer is an area of unrelieved pressure over bony prominence that leads to ischemia or death of tissue cells, and you have tissue necrosis. In a healthcare setting, pressure ulcers are a concern for patients, caregivers, and especially for medical personnel. Assessment and identification of the causative factors and preventative measures is imperative in the prevention and treatment of those at risk for potential or those who have actual skin breakdown. Now, the purpose of my speech is to outline the predisposing causes, identify the pathology, and identify methods of prevention and treatment of pressure ulcers. Pressure ulcers are known to cause serious pain, functional limitation, and emotional burden. In healthcare, the development of a pressure ulcer is regarded as an outcome indicator of the quality of healthcare that your facility is actually providing. Treatment is expensive, and there are legal issues related to the development of a pressure ulcer. Pressure ulcers have been described as one of the most costly and physical debilitating complications of the 20th century. They are third most expensive disorder, secondary only to cancer and cardiovascular diseases. Ulcers can develop in a few hours and they can take weeks and months to heal, sometimes years, and sometimes they don't heal. Therefore, effective prevention is important in healthcare facilities, and strategies such as identification of those at risk, repositioning, and treatment and nutritional support are critical in caring for those with potential and actual skin breakdown. So to understand a pressure ulcer, let's talk about the pathophysiology of an ulcer. Identifying those at risk for skin breakdown is an important first step in the prevention of ulcers. Often in the healthcare setting, we're not only concerned with the prevention of potential skin breakdown, but we're also dealing with actual skin breakdown. In this process of managing ulcers, it's necessary to understand the pathology of why the skin is breaking down. Before you can do anything about it, you need to know what's going on. So let's talk about the stages of ulcers. When there is constant pressure and lack of perfusion to the upper layers of skin, the area will develop into areas of erythema and induration. An area of erythema that doesn't blanch when depressed with the finger is considered to be the first stage of a pressure ulcer. At this stage, the damage might be reversed by removing the excessive pressure that is causing the ischemia as long as the skin is still intact. The ulcer is considered a stage 2 when there is an open wound and the barrier of the skin is lost. Therefore, if the skin is gone, it is now a stage 2, and at this point you're open for risk of infection and increased problems. With a stage 3, the ulcer is deeper and subcutaneous fat, muscle, and tissue might be seen at the bottom of the wound bed. If bone is visible, the ulcer is classified as a stage 4, and it is necessary to understand that a pressure ulcer can develop from non-blanchable erythema to a stage 4 in a matter of days. Also, something else to be aware of is a suspected deep tissue injury, SDTI. These are difficult because you can't stage them. It may look like a bruise, but you have no idea how deep that wound is or how deep the injury is. Therefore, you can't stage it. So it's a suspected deep tissue injury. As long as the skin is intact, that's how you classify this. It looks like a bruise. This is a place you might want to see over the coccyx and especially on heels. The heels look bruised, so that is considered a suspected deep tissue injury. Let's talk about risk factors of pressure ulcers. There's a large number of intrinsic and extrinsic factors that cause ulcerization, and they should be considered when assessing the risk of ulcer development. Malnutrition, poor circulation, and underlying diseases that impair mobility should be recognized and treated with an emphasis on the 2 cardinal principles: active promotion of movement and passive pressure reduction through frequent changes of position. Move your patients, turn and reposition your patients. Some of the intrinsic risk factors. The most important intrinsic factor or patient-related cause of a pressure ulcer is pressure exerted for an excessive period of time. The length of time that ischemia can cause pressure injuries varies among individuals, but as a general rule, This can be as short as 30 minutes or as long as 240 minutes. So think about someone sitting on a bedpan. You can actually get a pressure sore developing by leaving someone on a bedpan for too long, and I've seen that. Immobility of a patient increases risk because they can't regularly take pressure off vulnerable areas of the body by shifting the weight or changing positions. Other conditions that impair mobility are contractures, impairment of consciousness, decreased pain perception, they don't know that it's hurting, and the decreased ability to cooperate with mobility. Those who have compromised immune systems, the severe illnesses, or those who have multiple risk factors such as the elderly are at a definite increased risk for potential skin breakdown. The elderly account for more than 60% of the patients with ulcers because they're more likely to suffer from immobilizing diseases such as stroke, and because they have age-related changes such as skin, blood vessel, and other organs. They're not perfusing as well. Conditions related to cardiovascular disease, peripheral artery disease, congestive heart failure, diabetes, and problems with nutrition can decrease the supply of oxygen and nutrients to peripheral tissues. These intrinsic factors all play a role in the risk for development of pressure ulcerization. An intrinsic factor that you also want to consider is the neurological condition of a patient. If a patient has loss of sensory perception, or if they're unconscious, they will be prevented from feeling the pain of the pressure and may stay in a compromised position for too long and develop skin breakdown. Neurological conditions such as muscle weakness or paralysis would also prevent a change of position when there's increased pressure. Strategies that consider pressure disbursement, wound control, nutrition, general health, and systemic condition improvement are needed for preventing and treating pressure ulcers. Extrinsic risk factors. Let's talk about those. Extrinsic risk factors continue to remain to be the main causative factor of pressure ulcers. Extrinsic risk factors that play a role are pressure, shearing, friction, moisture, and the position you leave that patient in. Shearing is a risk factor to consider. Shearing takes place when the body glides over a surface and the skin and subcutaneous tissue don't glide. This happens when a patient is pulled up in bed without the use of a draw sheet. So think about it. The patient is pulled up and the body moves up, but perhaps the skin above and around the area of the coccyx stays where it's at, and you get that shearing force against the body, and that can cause tissue injury. Friction also contributes to skin breakdown when the skin is rubbed against a stationary surface, such as a bed sheet, almost like a carpet burn, and you burn off that top layer, or friction pulls that top layer of skin loose from the underlying tissue. Exposure to moisture is a very important extrinsic factor leading to pressure ulcers. The extrinsic moisture from perspiration, urine, feces, and discharge causes maceration of the skin surface. Excessive moisture on the skin also weakens the skin and makes it more susceptible to pressure, to shearing, and to friction. Position of the patient is a key significant extrinsic risk factor. The position of the body determines the pressure areas that may be susceptible to potential or actual breakdown. Think about the ears with the nasal cannula, the back of the head, the shoulders, the coccyx, the knees, the elbows, and especially the heels. Float those heels. Heels are a great potential to break down with someone who's immobile. Pressure ulcers can also be caused by items against the body, like a blood pressure cuff left on too long, nasal cannulas, catheters, and even bedpans. Foreign bodies can cause and contribute to pressure ulcers and the breakdown of skin in a very short time frame. So let's talk about implications for practice. Preventative care. When considering the prevention and treatment of pressure ulcers, focus should be directed toward taking care of the extrinsic and intrinsic factors. A patient's risk factor must be assessed and measures taken to promote active movement and passive pressure reduction with frequent position changes. Research suggests that malnutrition, impaired perfusion, and underlying diseases and symptoms such as pain must also be addressed. The implication is that ulcers can be considered preventable or potentially curable if pressure-reducing measures are put into place and there is increased movement and repositioning of the body. But research also suggests that pressure ulcers, when you consider the overall health of some patients, can't always be prevented. A goal is to incorporate assessment and decrease the preventable risk to lower the incidence of pressure ulcers. Now, support is that a high risk of patients with ulcers, if they are repositioned at least every 2 hours, they have a lower rate of developing pressure ulcers than those who are positionless frequently. Research supports this. Turn and position patients every 2 hours to get pressure off those bony prominences. Frequent manual reposition continues to be the primary method for prevention of ulcers in a healthcare or home setting. In addition to frequent repositioning, the skin of the patient should be clean, dry, and moisturized. Skin care should be addressed frequently when there's episodes of incontinence to avoid the breakdown of skin related to moisture. Let's talk about improvement of our knowledge and skills. Education concerning pressure ulcers should be looked at as a priority for all caregivers, not just those that are the healthcare professional taking care of that patient. Early identification of those at risk could be the most effective way to reduce the incidence of pressure ulcers and ultimately provide patient safety and care. Healthcare providers must make sure the patient or their caregiver understands what is being advised for them for prevention of pressure ulcers and that they adopt preventative strategies. In a healthcare setting, patients and caregivers need to be provided education on the intrinsic and extrinsic causes of ulcer development, the importance of moisture control, the importance of repositioning, and the importance of good nutrition. If actual skin breakdown is present, it is necessary to provide education to care for the ulcer and prevent additional skin breakdown or a worsening of that ulcer. In light of the growing recognition of pressure ulcers as an important contributor to patient suffering and the cost of health care, there is an urgent need for healthcare facilities to design, implement, and evaluate their interventions to prevent pressure ulcers in the different settings in which we work. Proper treatment requires resources in terms of both staff and money. That is why it is very important that prophylactic measures always be implemented in the home or in the healthcare facility to prevent the occurrence of pressure ulcers. The purpose of assessing risk and decreasing risk through pressure reduction, movement, promotion, and the treatment of all underlying illnesses is to lower the risk of actually developing the ulcer. Education about the care and prevention of pressure ulcers should be looked at as priority for all and not the sole responsibility of the healthcare professional. It is evident that early identification of those at risk of pressure ulcers can be channeled limited resources in a more effective way to reduce the incidence of pressure ulcers and ultimately improve patient care and ultimately improve the care that we provide in our facility. In closing, I'd just like to say that ulcers are a complication of illness that cause suffering, lead to serious complications, and increase morbidity. Reduction in the incidence of pressure ulcers can be challenging, but with preventative measures being taken by medical staff, patients, and caregivers, reduction of ulcerization can be achieved. So in closing, the last thing I'd like to add is move your patient, get your patient moving. If you can't move your patient, have your staff turning and repositioning that patient at least every 2 hours to prevent pressure ulcerization. Thank you.